Hello and welcome back to the Cancer Awareness Month. Today we are looking at breast cancer again. On the previous episode with Professor Kafui Akakpo, we looked at breast cancer. We largely talked about breast cancer in women, but this time he's also going to explain breast cancer in men to us, and then you'll share the process of diagnosing breast cancer, the decision making in treatment, and the treatment options in Ghana with us here on the Super Morning Show. Prof, welcome back to the conversation.
Thank you, Kojo, for having me.
Yeah, so like I said in the previous episode, breast cancer is one of the main things that led to us deciding on having the Cancer Awareness Month. And we've been talking about breast cancer for years. And it seems as though people still don't know that breast cancer doesn't affect only women, but affect men as well. And it surprises many people when we talk about breast cancer in men. Why do men also develop breast cancer?
Thank you, Kojo. So, the answer is a simple one because we also have breasts. However, the proportion of breasts is what differs.
You just made me look at my chest, Prof.
That women tend to have a lot more breast tissue compared to men. And then, of course, the structures in the breast that are supposed to produce milk in men are not as developed as those of females because we don't have as much of the hormone that is required to develop the breast, which is the estrogen. But it does not mean that we don't have little bits of it. We still do have little bits of estrogen there. So the proportion of breast in even men can differ from nothing to large, especially as you get older and you become obese. You would notice that your breast tissue actually increases.
Yeah.
Then, of course, you've got rare scenarios where some men actually do have larger breasts because they've got some hormonal disorders. And again, even for teenagers, sometimes when the growth spurt begins to occur, you would notice that they may have a slight increase in breast that disappears subsequently. So yes, we do have breast, and so we can be predisposed to getting breast cancer. It's just that the proportion is low. Usually, if you look at what has been put out there in literature, the highest proportion that has been reported in Ghana is about 3%, and the lowest is around 1%. So we are somewhere between 1 and 3.
Like, have you seen any of these cases in your practice?
Oh yes, we do see male breast cancers. At least in my practice, I probably have seen maybe about 100 men who have had
100 male breast cancers.
Yes.
Wow.
So it does occur. It's not uncommon for men to have breast cancer. They do also get. We also do get breast cancers.
But hypothetically, let's say if out of every 100 women, 20 would get breast cancer, out of every 100 men, how many are likely to get breast cancer?
Or maybe one or two of them will get it.
Okay.
And maybe 1 or 2 of them will get it. Yes.
I'm curious. I see a lot of friends who are into bodybuilding having large chest and breasts. Are these people at risk because they also have much more developed breasts than those of us who don't bodybuild?
Okay, so bodybuilding actually builds muscle.
Okay.
So if you bodybuild, what it means is that you're putting your muscles to work, and therefore your muscles will undergo a process which is an adaptation called hypertrophy. So the muscles will become larger just because you're pushing more weight, and the body knows that the what is required to push the weight is muscle. So, of course, that's not related to the breast tissue itself. The breast tissue itself is really made up of the duct system, then the fat that is in there, and then the fibrous meshwork that supports the ducts and fat. That's what makes up the breast tissue itself. So, a lot of the time, those who are exercise has always been a good thing and has always been protective. So whether it's in men or women, you still have, you are still protected if you are exercising.
Hmm. So the larger breast we see in our friends bodybuilding, it's more muscle and not the
Yes.
grape example you gave to us in the previous
No,
episode.
exactly. That's what it is.
Okay.
It's muscle. Yes, sir.
Now, how different are men's breast cancers from women's breast cancers, if there are any difference, and are the symptoms the same for both men and women?
Good. So, generally, the symptoms and signs should be the same. However, the problem has been that men traditionally do not recognize that they can get breast cancer. So they tend to delay in coming to the hospital because they assume it is something else. And so they just let it be. They just leave it alone for a long time. However, if you follow the same um, advice, if you look at your breast, you would notice that changes in it in relation to the skin or a mass that is in it that is not mobile. The same things, the nipple will change. There may be a discharge coming from it. And there's asymmetry. You would notice that one breast is larger than the other, or one breast has a different shape than the other one. Now, let me caution that because the breast in males is also smaller, what it means is that if you have a cancer sitting in it, it gets into the chest very quickly because you have very little breast to actually, for the tumor to grow. There's hardly any breast tissue there for the tumor to grow. So when it starts, it goes very fast. And if you delay, you would notice that you would go towards that stage where we say you are late stage and the disease is bad because it's left your chest already and it's gone into your lymph nodes. So generally for men who have breast cancer, you would notice that by the time they get there, the solution to the problem is taking out the whole breast and not a part of it because they've delayed so much so that the disease has gone beyond the local breast into other regional tissues.
Can I conclude based on this that male breast cancers are deadlier than female breast cancers because we don't get diagnosed fast enough, and when we are, because we don't have enough material for the cancer cells to grow on, it goes into other parts of our body quickly, and it makes it more dangerous.
I don't know if I should say that because the woman will start saying that because we are having some few breast cancers now, we want to claim the danger. So probably we should say that it all depends on your grade and then your stage and the type of breast cancer that you have. But the caution is that, yes, because of the size of our breast, which is not that large, and the fact that cancer can spread quickly to adjacent tissue, it does mean that men usually will present late. And then, of course, we also have a health-seeking behavior that usually means we wait a little before going to the hospital. And of course, until recently, the breast cancer months did not really catch up with us men. We assumed it's always a female issue. So we would not examine the breast and we would not pay any attention to it. So, yes, of course, what it means is that we are more likely to have late stage disease, which will mean that we are more likely to have a bad prognosis if we keep going along the lines of not being, uh, um,
Hmm.
not taking care of ourselves.
Hmm. We're talking about breast cancers here on the Cancer Awareness Month on the Super Morning Show. My name is Kojo Akoto Boateng, and I'm here with Professor Kafui Akakpo, and he's explaining breast cancer in men to us. And Prof, now let's get into the diagnostic process. In the previous episode, you explained breast cancer in women. Now you've given us some knowledge about breast cancer in men. What process do you go through as an anatomic pathologist? Yes, I got it right this time. To make a diagnosis of breast cancer.
Good. So when a lump or a concerning lesion is found in your breast, maybe at imaging when you go and do a screening, or you feel a lump yourself, or your health worker feels a lump, one of the things that they would do is that they would take a piece of it, they would do a biopsy, and that is the same for men. So you always need a bit of it just to be able to understand the disease and type it and know all the things that are driving the disease before you start your treatment. So you just take a bit of it. And usually what will happen is that they'll put that in a fluid. That fluid is called 10% neutral buffered formalin. Just a bit of it. And it's supposed to stop the tissue from getting rotten in transit to the anatomic pathologist. So once that is taken, a number of calls will be taken from that, and that will be given to you, and you send it to a pathology lab, like Pathologists Without Borders. When you get there, that will be taken, and then it will go through a process we call tissue processing, and then it will be stained, and the pathologist will now sit down, look at it, and using standardized methods, say, yes, we agree this is breast cancer, and it is of this type. There are quite a number of types of breast cancer. And we do that typing because, again, we want to make sure everybody's disease is personalized, because the breast cancers are not the same. And different types have different behaviors and respond to treatment differently. So we also go on and look at little things that show us that this tumor is being driven by estrogen. And let me add that the breast cancer in men is also driven by estrogen and progesterone, because we also have estrogen and progesterone, but in small amounts.
Does it mean that, Prof, does it mean that the hormone receptor positive analysis is also done for men?
Exactly. So we'll do the same hormone receptor analysis for men, and we'll look for the human epidermal growth factor receptor, the other receptor that I said is related to growth factors. We'll also look for it in men too. When we are finished with that, I did not add that in our setting, we add another marker. We call it Ki67. And that one is a marker of proliferation. What it means is that it checks how fast the tumor is actually dividing. And so you can see from that, oh, this tumor is growing very fast, or this one is growing a little slowly. Putting all those things together, you can profile the person's cancer. Then now you go on to other investigations that tell you the extent of the disease. So when we come to extent, you want to find out why the disease is, where has it gone to? As somebody will say, it didn't move saying, so is it just in the breast? Has it gone into the armpit? Has it gone into the chest? Has it gone into the brain? How far has the disease gone? And even if it is only in the breast, what proportion of the breast is involved by this? And the radiologist can actually measure it and tell you, oh, this thing in your breast is just 1 millimeter, 2 millimeters, 3 millimeters, 4 millimeters, can tell you the size of it. So the size actually then relates to how much of your breast has been taken by the disease. And eventually that is what we call staging. And it gives an idea of the prognosis of the person, which also means how well the patient is likely to do. And it's just in percentages. It doesn't mean all the patients will behave the same way, because you've got other things in the background, like the estrogen receptors, human epidermal growth factor, 2 receptor or HER2 receptor in short. And then you've got other things that come into play to make a person's cancer what it is for that person. So we will do this for both male and female breast cancers. Then, of course, now you go on to have what they call a multidisciplinary team meeting. And at this meeting, you have every player there. And it's the same for men too. Everybody comes in. The patient is discussed. Sometimes even the patient sits in that meeting and the discussion is had. And then subsequently, we have an agreement as to how to proceed with the management of the patient. And everything will be revealed to the patient. The patient will be told that you came in early enough, your disease is at this stage. It means that your outlook is this, or you came in very late, your disease is at this stage, and therefore these are the treatments that we can use to try and see if we can sort the issue out. It's an open discussion, and any survivor that you have would be able to run you through this very well, so that people are not scared of going to the hospital because they feel like, oh, when you go to the hospital, you just take my breast away. No. The longer you wait, the more likely it is that when you get there, they will do that. The earlier you go, the less likely it is. If you go early, the less likely it is that your disease would have gone to a late stage, and therefore it will not require that kind of treatment. Your treatment would be far more drastic. It will not be as drastic as if you had a late stage disease.
So, on diagnosis, what you've been taught generally is to examine physical examination to see if you have a lump. If you see any lump, you go to the hospital and they use radiology to check If they find that, then you do the biopsy, you take the sample, and then you establish what type of cancer cell it is, right? Doc, am I getting the process right?
Exactly. You have the process right. Yes.
Then once you do the biopsy, further observation will let you know whether the cancer is the cat type or the tiger type.
Exactly. You grade it to know how aggressive it is.
And after the grading, the various professionals get together to discuss how you are going to treat it.
Exactly. And in addition to the grading, we do what we call staging. And the staging is just to know the extent of the disease, how far has the disease gone, how has it spread in. So if I use the tiger cat analysis in the house, has that thing gone everywhere in the house, or is it just restricted itself to a particular room that you can control it? So you find that out, because if the cancer has gone outside of your breast and is in your liver, the treatment cannot be the same as when the cancer is just in your breast. And if you have a 1 centimeter tumor in your breast, nobody should take out your whole breast. They'll just take out a bit of your breast and leave the rest for you, because the cancer is small. It's not big. But then if you go and then the cancer has become 15 centimeters, how big is your breast? They can't leave it. They have to take the whole breast. And that is when a lot of people get their entire breast removed, and then they complain that when they go, their breast is taken, and when their breast is taken, it doesn't take a long time, then you die. It is because the disease has reached a stage where it's not just that it's 15 centimeters. It's 15 centimeters. It has also gone to your lungs, and it's probably gone to your brain, because the larger the tumor, the more likely it is that it has gone outside of the breast. As the tumor grows large, nourishment in the breast reduces. So the cancer cells know that there's not much space here for us to stay. So they go elsewhere. And at that time, they would have gone into your lung and your brain. So even if they take your breast out, it is a treatment that has come in a bit too late, and you require a bit more drastic. You need more drastic measures to be able to completely uproot that disease, if that is even possible.
So for you doctors, your first approach is to save the human life, is to save the organ. But in the cases where the cancer has spread way too far, you'd attempt to take out the cancer. So you take the breast, but if it's gotten into the bloodstream and it's gotten into other organs, that's where even when you take out the breast, people still suffer other forms, and then before long they die. So the most important thing is to get examined, get diagnosed early, so that we can give you the help you need.
Exactly. That sums up what I said very well. So it's stage matters. Early diagnosis will save you.
And with the stages, we have stage 1 to 4. And stage 4 will be when you are at the most advanced stage, and usually, if you don't take care, we'll lose you.
Exactly. So at that stage, the first sign of it locally is the fact that your breast would get completely disfigured and there's an ulcer. So once the skin of your breast gets ulcerated, at that stage, you have already reached stage 4. And there are other changes that come in. You would start having this lymph node swelling in your armpits, and sometimes you start coughing. And then sometimes you may even have a stroke, because the tumor is in your brain and complete. So you present like you got a stroke, but it's just because you got the tumor in there. Then the tumor can go to your liver. And when it goes to your liver, one of the first things that you probably will see will be the fact that you become jaundiced, because your liver is not functioning well. So that is what we call metastasis. And what it means is you have got the discontinuous deposit. A deposit of cancer that is not linked in any way to the one in your breast, because it went through certain pipes in your body, like your blood vessels and your lymphatic vessels. So it's disconnected, because a tumor cell can just go into your blood and move on, or your lymphatics, and move on to other parts of your body that are richer in nutrients.
So I'm going to repeat the processes again, if I got it right on the screening, because now I think between the two of us, we all agree that screening actually prevents all these things you are talking about to get to stage 4. And so there's a self-breast examination, which we've been taught generally. Then you go and get a clinical breast examination, right? So when you do a self-breast and there is a problem, you go do the clinical, which will then result in the mammography and all the other things you do. Am I still on track, Prof?
So even before the self-breast examination and clinical breast examination, you can actually go get your mammography done, and you can also get an ultrasound done. And rarely, they may have indication to even use an MRI. So all these are imaging, and they are superior to the examination that you do yourself or the doctor or the nurse will do. The imaging is always superior to it. In the countries where they take screening very seriously, what they do is the imaging. That means that you do the ultrasound, mammogram, and rarely the MRI. And those three are the ones that we recommend for screening. However, if you can't do that, then at least just examine your breast.
How
If you cannot
how
go,
often should we do these things? So breast examination, the imaging. How often must we all do this?
so in the case of the breast exam, the imaging, number one, first you have to look at the risk of the person, and the age even matters. When do you start? So usually we say you should start at 40, and I'm sure the surgeons would explain this even better. So you should say you will say you should start at 40. However, if you've got a patient, if you've got a family history of breast cancer, that means there's somebody who has breast cancer in your family, like a first degree relative. And when we say that, we mean your mother or your mother's sister. Any of those very close relatives have breast cancer. Then it means that you probably are at risk of having breast cancer, because that is one of the risk factors that I mentioned, that family history of breast cancer is important. So in that case, instead of starting your screening at 40 years, which everybody else you would have to start earlier. And some people will even say that you should start maybe even 10 years earlier. But there are guidelines to that. For every population, they would have recommendations. So when you start that, at that age of 40, when you have started, they would say that every year you should go and get the mammography done. And then there's a point where they can even say, oh, you've done it for a couple of times, you've not found anything, so maybe you can extend it a little bit. But for the breast self-examination, I think the recommendation is that every month you should at least touch your breast, and the more you touch it, the better. So it doesn't mean that you should even wait for long intervals. It's your own breast, it's on you, so you can touch it as often as you want. And when you see changes, you should go ahead and get advice. So the self-breast examination is supposed to be done in quick succession, because it's not as sensitive as the imaging methods that I mentioned. And so the imaging, the intervals are a bit more prolonged as compared to the self-breast examination. But there are guidelines about how to improve the sensitivity of these methods and the interval within which you can carry out the examination.
And do we have as many hospitals as possible to help with these examinations across the country?
Yes, for self-breast examination, no hospital required, you yourself. But then the next thing that happens is that you have to go and do a clinical breast examination. And yes, the clinical breast examination can be done by nurses at every hospital. There are specific hospitals that are, however, available to actually walk the breast cancer patient through the journey of breast cancer. Some of these hospitals include Cape Coast Teaching Hospital, Kolebu Teaching Hospital, Konfanochi Teaching Hospital, Peace and Love Hospital, Tamale Teaching Hospital, Brekun Teachman Hospital, and Bator Catholic Hospital. There are hospitals that are around, and every hospital that has a certain stature in terms of regional or district level, they are able to do some of these things. However, the mammograms are the problem. We don't have as many mammograms in this country as we need to have. And this is something that we should carefully consider, in line with other things like having centers for radiation and cancer management. As we speak now, there are only 3 cancer management centers for radiation in Ghana: Sweden Ghana Medical Oncology, Kolebu Teaching Hospital, and then Konfanochi Teaching Hospital. Up north, there's none. So everybody who requires radiation has to come to the south, which is something that we need to look at. And the same with the mammograms. The mammograms are not many in this country. And if you want to screen a large population, Then you need mammograms dotted around the entire country to allow people to walk into a hospital and have a mammogram.
But at least every regional hospital must have mammogram capability.
Exactly.
Every regional hospital must be able to do radiation therapy as well.
Exactly. In a system that works well, that is what you are aiming at. In a system that works well, it shouldn't be that difficult. Every regional hospital can have that.
Now, Prof, let's spend our last minutes together to talk about the treatment options available in Ghana. At least radiation, you've told us that only 3 hospitals, Sweden, Ghana Medical, Kolebu, and then Konfanochi Teaching Hospital. But what other treatment options are available in the country? And when and how do you choose to take this or that?
Okay, so thank you for that question. So I'll try and break it down to make it as simple as possible. So if you look at it, really what we want to do is we want to do local treatment, regional treatment, and then we want to do systemic treatment. So when I say local, what I mean is the tumor is not that big. So it means that it is possible for you to take a bit of the breast with the tumor in it and leave the rest of the breast. And that is actually what is recommended now, what they call a wide local excision. They just take a section of the breast out and then they leave the rest of the breast. So that's surgery. And the surgery can vary from what I just described to major surgery where they take out the entire breast and remove the lymph nodes that are in the axilla or the armpit, because those are the first lymph nodes that drain whatever is coming from the breast. Now that is considered regional treatment because it's a whole region that you are now actually targeting. You can also do that wide local excision and remove the lymph nodes, or you do a mastectomy. When we say a mastectomy, it means you remove the breast and then we say axillary lymph node dissection, you add the lymph nodes in the armpit to it. Now, in addition to that, you have systemic therapy. Now, this systemic therapy includes a number of things. You have chemotherapy, which is conventional. You give the person a drug that targets all growing cells. But there are new drugs, and I mentioned that you have targeted therapy. These ask the question, what is driving this cancer? And then you have things like the estrogen receptor antagonists or blockers. These block estrogen from working, and so your tumor will not grow because the estrogen that you are producing will not have an effect on the tumor. Then you have other drugs like HER2 targeted therapy, which in that case you have Herceptin or trastuzumab. These drugs are target the HER2 receptor. So when you have too many of them, they'll block it. Even now, there are a subgroup of them that are called the antibody drug conjugates, which are superior to, okay, maybe I shouldn't say superior, which are more sensitive. They have a better way of acting. A better way of acting in the sense is that they combine the targeted therapy, which is the antibody to HER2, and then they have the chemotherapy combined. So when it goes into your system, the one that works on the antibody, that is the HER2, will work. And then some of them have got what you call a bystander effect. So the drug goes into your system and releases chemotherapy into the neighborhood, just the region of the cancer, so that the other cancer cells that don't even have HER2 will also die. And these are in the system now, the antibody drug conjugates.
Are they also on insurance? Because you mentioned earlier that some of the medications are on insurance.
Good. So the chemotherapy agents are on insurance. And then I mentioned trastuzumab, which is the first drug that was developed for HER2 amplified cancers. And trastuzumab is on insurance. However, the antibody drug conjugates are not yet on insurance. So that one, you have to buy it yourself if you qualify for it. Most of those are now used in a metastatic setting. So it's a final thing you do when your disease has become so late that you can't benefit from the conventional treatments. Then there's immunotherapy. Immunotherapy just means that your body is able to recognize the cancer cells as foreign and mount an immune response, just like it mounts an immune response to a flu or to malaria or to any other infection for that matter. The cancer cells, when they get into your breast, when the cancer cells develop in your breast, one of the things that the cancer cells do is that they kind of I'll use the word whisper to your system that, you know what, we are friends. So don't do anything. Just let me be here. So your body does not recognize them as foreign and doesn't mount a response to it. And the cancer cells do that through a number of methods. But now it has been found that you can actually give some drugs that help your system to say that, no, you are foreign, out, fight you. And so those are like immune boosters, which now boost your immune system to fight the cancer itself. And these are called the immunotherapy agents. So you have these systemic therapies that are available now. Of course, the regional therapy, we mentioned earlier, radiation. That's why I didn't bring it. It's so important to. So radiation is one of the things that is used to actually consolidate the local or regional treatment that has been given by the surgeon. All these said, there are other very important things that a person must go through when they have breast cancer or when they are diagnosed. They include things like a good diet, exercise, emotional support from their families, their friends. It's not a contagious disease, so you shouldn't lose friends and family from that disease. But you find that people have stigma, people are stigmatized, and therefore they don't get the emotional support. But health encompasses a lot of things, including your emotional well-being. So it is important that you have that to sorted out well. And those who have had the support that is required, the needed family support or friend support or a group support system, have done better than those who were left on their own without the support, because that alone is one of the things that boosts your immune system and that helps you to also fight the disease. So these are the treatments that are currently available.
Let me see how good I am as your student. So treatment options available: surgery, there's the lumpectomy and the mastectomy.
Exactly, or wide local excision. Yes.
So the mastectomy is when the whole breast is taken off.
Exactly. And then the wide local excision or lumpectomy is when you have a small, just the lump with normal tissue taken.
Yeah. And chemotherapy is when we use drugs to fight the cancer cells.
Exactly. But in this one, you are fighting all fast-growing cells too at the same time, because the cancer grows fast. On this disease, this chemotherapy will target all those cells too.
Radiation therapy is where we use radiation to fight the cancer cells. And you said you have only 3 places for that therapy in the country.
Exactly.
Hormone therapy is when you use hormones to suppress the growth of the cancer.
Exactly. So that one is targeted therapy, and the target against hormones. So what it means is that you're blocking the hormones from driving the cancer.
And that is related to the HER2 targeted treatment as well.
That one is related to the ER, and the HER2 is also targeted treatment, but that one relates to what they call the human epidermal growth factor receptor.
So far, I'm a 50/100. And the last one is the immunotherapy.
Your last one is immunotherapy, and
which informs the body that cancer cells are not your friends, so fights them.
Exactly, so fight it, and they mount an immune response to it.
At least 60/70/100. Many bad.
Exactly.
Now, Doc, I know there's a lot that goes on post-treatment. Some people, like you said, have problems, and they basically don't get the right emotional support. There's some people, because of these things, sometimes go for plastic surgery. I've heard of breast reconstruction surgeries and all those. Do we do those things in Ghana? And when is it advised that we do that?
Oh, yes. The breast group or the breast team in Kolebu, as an example, have a very close relationship with the plastic surgeons. And just when the decision to do the surgery is made, that decision to reconstruct the breast is also made. So the plastic surgeons are on board from the get-go. And once they have done the breast surgery, they would activate the processes that are involved in preparing your breast to receive the tissue that is required to reconstruct your breast. So it's done. For those who want it, the breast is reconstructed. And it becomes necessary because they take out the entire breast or a chunk of it. That's when they will reconstruct. But if that is not the scenario, then generally you may not need that. But the plastic surgeons are good at that. And we have a number of them in the country doing that. So it's care that people are receiving.
Wonderful. Wonderful.
That kind of
Wonderful.
thing.
It's been great talking to you, Prof. Akakpo. You've really enlightened us. This is the third episode you've been on for this series, and I've learned so much from interacting with you from the beginning to breast cancer 1, breast cancer 2. Now, before we wrap up our session with you, any final message for listeners?
Yeah, thank you. I would want to reiterate my point that if you find this disease early, that is what saves lives. So early detection is key and it saves lives. And I also want to say that there are a lot of people who are willing to support breast cancer patients, from survivors to breast care physicians and groups that have dedicated their time to breast cancer care. So if you are in doubt, it is good to approach any of these groups, to call any of the survivors. And there's a society, it's called the Breast Society of Ghana, that champions breast care in Ghana. And that society has been phenomenal. It's led by Dr. Josephine Insafo, and they are in Kolibu, and they've supported breast cancer care across the country. There are other pharmaceutical companies that have also been very key in the fights against breast cancer, like Roche. Roche has supported immunohistochemistry for typing these breast cancers for a very long time, and they are doing a good job with it. Pfizer has supported with improving pre-analytics and making sure that breast tissue that we get is working well or is preserved well enough to be able to really type. So I must commend all of them, and I must really assure everybody that early detection saves lives, and you must get your breast checked so that if you have any problem with it, it is detected early and you're saved.
Early detection saves lives. Get your breast checked. There are support groups, and let's work together. We can fight this, and we can win this war against breast cancer. Thank you so much, Professor Kafui Akakpo. In the coming days, we'll be learning about cervical cancer and ovarian cancer here on the Super Morning Show. Thank you so much for listening. My name is Kojo Akoto Boateng. Once again, Professor Akakpo, thank you for your time this morning here on the Super Morning Show.
Thank you for having me, Kojo.
It's a wrap. My name is Kojo Akoto Boateng. The Super Morning Show continues. This will be shared on Spotify and the other podcast platforms. So just get it, spread it around, and together, let's win the fight against cancers in the country. Keep listening. This is the Super Morning Show.